malaria. But if Mozambique, Eswatini, Zimbabwe remains on the status that they are still reporting well over 1 million cases of malaria, there is no way that South Africa could have eliminated malaria by now. Henceforth, we decided together we'll defeat malaria 11 years ago. Henceforth, we consulted with our principals, our heads of state and government, and agreed that, yes, time had come that we form an initiative primarily to collaborate together to make sure malaria is eliminated within these close neighboring countries of first 4 frontline countries, Botswana, Eswatini, Namibia, and South Africa. And second line countries, Angola, Zambia, Zimbabwe, and Mozambique. We decided collectively, as I said, with a mandate given by our heads of state, to form what is now known as SADC Elimination 8. What then is all about this? First, it has, in terms of the structure, the E8 Ministerial Committee. The E8 is governed by a ministerial agreement signed by the ministers of health of the 8 member states that I had just said earlier. The institutions of the E8 are, 1, the E8 Ministerial Committee, which is the supreme decision-making institution of the E8. You may look on that organogram there. Second is the E8 ambassador. The E8 ambassador serves as a glue between these ministers and the E8 Secretariat. He supports the E8 Ministerial Committee by brokering engagement at a ministerial level. As I was leaving office 7 years now, about 7 years ago, my colleagues, having realized that I was a co-founder, I'm a malariologist, I have that institutional memory, decided that I save to support their cause, given the high turnover of ministers. We have had some challenges, of course. How will I make this? But with the support from our partners, I have now saved for 6 years. And I can tell you, I have been moving in all these 7 other member states, including my own, primarily to support these ministers who are coming in. What is E8? What is it that we need to do in order to eliminate malaria? That is now followed by the E8 senior officials who serve as a link between the technical and policy aspects in the implementation of a regional approach towards malaria elimination. As we know, Director Generals, ED, Executive Directors, they are serving as accounting officers. The following is followed by the E8 Technical Committee, which develops, reviews, and implements technical and strategic guidance that will accelerate progress towards malaria elimination. This is for me the engine of if we are to see malaria being eliminated. Then comes the E8 Secretariat and its independent board, who are responsible by the coordination, liaison, and monitoring of the operations of the E8, providing administrative and secretarial support for the work done through the institutions of the E8. This is indeed an independent. Its composition includes, amongst others, legal expertise. As we know, its chair, by the way, is from even a non-malarious country, Lesotho. And some of the board members are simply business people with the interest of seeing that malaria is eliminated. And finally, we have the E8 Secretariat and its independent board, who are responsible for the coordination, liaison, and monitoring of the operations of the E8, providing administrative and secretarial support for the work done through the institutions of the E8. It is headed by an executive director, currently Dr. John Chimumba. Going forward, let me say this that I did not say in the beginning of my introduction by recognizing who is the first, my brother, Dr. Zweli Mkhize, Minister of South Africa. As of yesterday, as I said earlier, he is now serving as the chair of the E8 Ministerial Council. I would also want to recognize my other brother there, Honorable Aaron Mabuza, Provincial Minister of from Mpumalanga. Then, as of yesterday, the E8, the technical team, is now chaired by none other than our moderator, Dr. Devanand Patrick Monasa. All the 7 technical working groups will be chaired by the Republic of South Africa. Looking forward to the delivery of the first and second country, our plea, our dream, as of yesterday, is that during the chairmanship of South Africa, we may see at least 1 or 2 countries of the 4 frontline countries having been declared by the WHO as having malaria-free. We want to see that Dr. Zweli Mkhize is holding high the flag of the SADC Elimination 8, wherever he goes, attending these international meetings, including the UN, Africa, at AU level, at SADC, wherever he is, we want to see Zweli Mkhize incorporating the private sector to work with governments to see to it that domestic funding is in place, not that elimination should be decided by Seattle and or by Geneva through the Global Fund. We want to see to it that he will be talking to the heads of state of the E8 SADC. By the way, finally, the heads of state and government themselves 2 years ago, here again in Namibia, signed a Windhoek Malaria Declaration, committing themselves to this cause, that it will no longer be the 8 member states, but going forward, it should be the entire SADC member states. The meeting of last year mandated the SADC Secretariat and the SADC Elimination Aid to see to it that the whole mandate of that declaration is being operationalized. That is about the elimination, the E8 elimination. Thank you very much indeed for your kind attention.
Thank you very much, Ambassador Kamwi, for those inspiring words, for your commitment, your dedication and passion to the cause for malaria and malaria elimination. For those of you on the call who don't understand, malaria elimination is getting to zero local transmission of malaria. Minister Kamwi, your challenge to us is accepted. We will do our best to work with you and the region to deliver on the promise for Elimination Aid. Thank you very much. We now move our attention, and it's my great pleasure and honor to introduce to you our very own Minister for Health, Dr. Zweli Mkhize. Dr. Mkhize is a medical doctor by training. He currently plays a key role in leading South Africa's response to COVID-19 pandemic. Under his leadership of the health sector, South Africa has received several accolades and acknowledgements from the World Health Organization and the United Nations Secretary General. I must pause here for a second to acknowledge that Dr. Mkhize is also just one of the survivors of COVID-19. We're very grateful that he could make it here today. Dr. Mkhize, we will remove you as one of the active cases, and we'll add you to the recovery statistics. Thank you very much for joining us today. Dr. Mkhize also served as a Minister of Cooperative Governance and Traditional Affairs in 2018-2019, where he led from the front in searching for solutions to various governance and financial challenges affecting municipalities. Dr. Mkhize has a passion for good governance, efficiency, and properly run functional and responsive government institutions. He was the member of the Executive Committee for Health from 1994 to 2004, and the Minister for Executive Committee for Finance and Economic Development, the leader of government business in KwaZulu-Natal from 2004 to 2009, as well as the Premier for 2009 to 2013. So quite an illustrious career so far. At the same time, Minister Mkhize, we're very grateful to have you as our leader and committed to the cause of improving the lives of all South Africans. But most recently, and you've just heard now from Dr. Richard Kamwi, a latest accolade, Minister will now chair the SADC Elimination Aid Ministers for Health Council, leading the malaria elimination initiative in the Southern African region. Congratulations to you, Minister. And with those words, we hand over to you to give us your brief on addressing community involvement is key to achieving zero malaria and zero malaria elimination in South Africa. Thank you very much, Minister. Over to you now.
Thank you very much, Dr. Patrick Munasa. Thanks for your very kind introduction, and thank you for welcoming back from the COVID-19 list. I'm sure you have seen that the numbers of recoveries have increased to 91%, and I do believe that's because you have added more people into that list. But thank you very much for managing this session and all the work that you do in this particular field. Honorable Ambassador of the E8, Dr. Kamwi, thank you very much, my brother. Thanks for your very, very warm and encouraging words. Indeed, all of us in this field do know that your role is a very important role, as the ambassador, particularly because of your passion, your technical knowledge of the subject, your institutional knowledge, and the fact that you have the ability to move between technical officials, ministers, heads of states, to promote the fight against malaria, which is a very, very important fight in our continent. And so I want to say thank you for your sense of confidence and thanks for being part of this very important occasion. May I therefore also welcome and acknowledge our esteemed panelists, Professor Karen Barnes. Thank you very much for your presence. Mr. Mabuza, Aaron Mabuza, thank you very much for your presence as well and participation, and Dr. Jayashree Raman. We're looking forward to hearing a lot more on this subject from you. And then all the participants in this webinar, I have noticed that the numbers have been increasing quite fast, and certainly does show a lot of interest on the subject. Members of the media, ladies and gentlemen, today we commemorate the SADC Malaria Day in memory of those who have lost their lives from malaria, and salute those who fight this disease from the front lines to the boardrooms each and every day. In the past couple of decades, outstanding progress has been made globally, evidenced by 2019 World Malaria Report, which was released by WHO. The report states that malaria cases decreased globally from an estimated 251 million in 2010 to 228 million in 2018, which is a 9% decline. Most cases, which is around 213 in 2018, were estimated to have occurred in the WHO region, Afro region, which is 92%. Now, if the whole world, the Afro region carries 92%, it does give you an indication of the sense of responsibility that we as the African member states carry to actually fight and eliminate this problem. Followed by those in the WHO Southeast Asia region, they've only got 3.4%. And those in the WHO Eastern Mediterranean region, it's only 2.1%. So it is very clear that this is largely a challenge that the African continent has to actually face and fight and eliminate. In the Southern African Development Community region, the WHO estimates that 3/4 of the population is at risk of contracting malaria, with 35 million of these being children under 5 years of age, and approximately 8.5 million being pregnant women. We would therefore classify the level of malaria transmission as highly endemic to stable all year round. Whilst many parts of Africa have a high burden of disease, some Southern African countries, including South Africa, report relatively lower transmission rates. South Africa has made steady progress in reducing malaria morbidity and mortality over the past decades. Malaria cases have decreased by 78% from 64,622 cases in 2000 compared to 13,000 in the year 2019. And malaria deaths have decreased by 82% from 459 to 79 deaths between year 2000 to 2019. South Africa is one of the 4 countries in the SADC region targeting malaria elimination, defined as zero local transmission by 2023. As some of you may recall, last year in July, I launched the National Strategic Plan for Elimination of Malaria in South Africa by 2023. And at the 5th Malaria Research Conference co-hosted by South African Medical Research Council, the University of Pretoria and National Department of Health, this was a joint program that we had hosted. The National Strategic Plan places emphasis on key interventions areas such as: 1 is the provision of effective leadership and management, which is key; strengthening and sustaining surveillance systems; robust communication with the public; universal access to anti-malarial tools; and then coordinated cooperation with neighboring countries, particularly those that present significant burden of importation of malaria. Reflecting on the last point, indeed, the high number of imported cases from travelers and workers is a phenomenon that requires a particular approach to the management of malaria epidemic. In this regard, we work with the Elimination Aid Initiative and the Musaswa, which is Mozambique, South Africa, and Swaziland, Eswatini, initiative to strengthen malaria control and elimination in the bordering districts of our countries. This year's theme for SADC Malaria Day 2020 is community involvement is key to achieving zero malaria, with the slogan, "Together we defeat malaria." Our message to communities that are affected by malaria and travelers to malaria endemic areas is to take the necessary precautions to prevent contracting the disease and seeking treatment as early as possible when they experience signs and symptoms. Malaria is a preventable and curable disease if detected early and treatment started promptly. It is therefore important to remind communities at risk and travelers to malaria endemic areas that malaria is a life-threatening disease caused by parasites that are transmitted to people through the bites of infected Anopheles mosquitoes, which generally bite at night. Malaria is preventable, treatable, and curable. Everyone in malaria areas is at risk of contracting malaria, but there are some who are more vulnerable, including children under 5 years of age, pregnant women, and people with compromised immune system, travelers from non-endemic areas, and immigrant workers. If not diagnosed and treated within 24 hours, malaria can progress to severe illness and death. Malaria's symptoms appear within 10 to 15 days after the infective mosquito bite. The symptoms include fever, headache, chills, and vomiting. If a person suspects that they have malaria, they should immediately consult their healthcare providers to be tested and treated. Travelers from non-endemic areas to malaria endemic areas and countries are vulnerable to these diseases and need to take preventative measures. Individuals are therefore advised to take personal protection methods when visiting malaria endemic areas and outside South Africa, within and outside South Africa. You know, my brother, Ambassador Kamwi, I often tell the story of how, as I worked particularly in Zimbabwe, that malaria was so endemic that we always thought of malaria even if someone had flu. So before we find out if you have flu or a pneumonia, we'll give you treatment for malaria. And by the time all the tests and the results come back, we already know whether it's malaria or not, because malaria responds so rapidly to treatment that within 4 hours, somebody is already much improved. And it actually kept a high level of suspicion amongst the doctors. And it's important when you look at that issue, because the rest of the countries, particularly in some of the non-endemic areas, people who have traveled from endemic areas can easily succumb to malaria because people don't think about it. And this is something that we have seen, tragic deaths as a result of malaria, simply because the professionals in that area are not really in a high suspicion index, having a high suspicion index on malaria. So education, public education becomes very important. Well, ladies and gentlemen, COVID-19 has complicated issues of public health, and malaria has not been spared of the disruption that have come with the unprecedented pandemic. What is key for the public is to realize that malaria symptoms may very well mimic COVID-19 symptoms. It is therefore imperative that when one experiences flu-like symptoms, that one seeks medical attention as soon as possible, if that attention is through digital or telephonic platform. It is critical that patients take note of their signs and symptoms and give detailed travel histories and histories of contacts with other people with flu-like symptoms. I'd like to take this opportunity, therefore, to clarify some conflicting messages in regard to mitigation measures for malaria and COVID-19. Whilst we encourage closing windows at night and the use of fans and air conditioning for malaria, the opposite is encouraged for COVID-19. That is to ensure the elimination of COVID-19 particles in the air. We encourage opening of windows to allow draft of fresh air in closed spaces, and we totally discourage the use of fans or air conditioners in enclosed spaces. Ladies and gentlemen, the new normal demands that we apply our minds and adjust to the presence of COVID-19, which is wreaking havoc in our communities and economy in ways that malaria never has. Let us therefore be mindful and take all necessary precautions as we battle with both pandemics and balance the mitigation measures accordingly. Let me conclude by expressing my deep humility and appreciation to the SADC Elimination 8 Ministers' Council, particularly that of Namibia and Angola, and of course, all the members of the Elimination 8, for nominating and subsequently appointing us to chair the council for a 2-year term. This is a great honor for myself in South Africa, and I wish to reaffirm my commitment to drive and lead the campaign to eliminate malaria by 2030 with diligence and passion, and look forward to contributing to the attainment of this goal. We have interacted as ministers of SADC on this matter. I do know the passion and the energetic approach that all the ministers have committed themselves towards fighting malaria to ensure elimination. We all agree that part of the contribution of the elimination of malaria is the boost to tourism, where we know that people who are moving around visiting different parts of our countries, beautiful countries, will actually be even more confident to visit our Southern African region when we know that we have eliminated malaria. So it is not only the issue of ensuring healthier communities who will not succumb to one of the major killers in the continent, but it is also a boost to our tourism industry and all other parts of our industries, such as transport, logistics, which require a large movement of our people who can do so without the fear of contracting malaria. With all those words, therefore, colleagues, friends, ladies and gentlemen, I just want to thank you at this point and say that we continue to commit ourselves to fight for the elimination of malaria. Thank you very much, Program Director.
Thank you very much, Minister, for those words on this SADC Malaria Day in South Africa. I think congratulations is in order. Obviously, there's lots of work ahead of us to be able to champion the cause of malaria in South Africa and in Southern Africa. And also, I think, Minister, for you to highlight that South Africa's target for elimination of malaria is 2023. It's just around the corner. So obviously, we need to roll up our sleeves and get on with the work. But the last point that you raised is very important, the messages to the community. Malaria is preventable, it is treatable, and it is curable. So it's important for communities to realize that they must seek treatment early when they get those signs and symptoms. Colleagues and attendees of this webinar, we now move into the second component, which is the technical component. We have 3 expert panelists today. The first being Professor Karen Barnes. Professor Karen Barnes co-chairs the South African Malaria Elimination Committee together with Mr. Aaron Mobusa. Professor Barnes is the Professor for Clinical Pharmacology at the University of Cape Town and Director for the Medical Research Council's Collaborating Center for Optimizing Anti-Malarial Therapy. Karen also leads the Southern African Regional Hub of the Worldwide Anti-Malarial Resistant Network. Karen has over 25 years of experience in the treatment of malaria, research, and policy making nationally, regionally, and internationally. I've worked with Professor Barnes for several years now, and I can tell you she's a very dynamic, hardworking, committed person. The second panelist we have for you this morning is none other than Dr. Jayshree Raman. Dr. Raman is the principal medical scientist at the National Institute for Communicable Diseases. Her research focuses on emergence and spread of anti-malarial drug resistance in Africa. Jayashree, as we know by, is involved in developing and facilitating diagnostic training courses for malaria health workers and postgraduate researchers. Jayashree is also a very active member of the South African Malaria Elimination Committee. Jayashree is a member of several working technical committees, one being Research Technical Working Group for the Elimination 8 Initiative. The next group that Jayashree is also involved in, she's a board member of the Pathogen Genomics Diversity Network for Africa. And this is an African-led research network investigating genetic diversity and drug resistance of pathogens that negatively impact the health and well-being of Africans. I've also been very closely associated with Jayashree, and I can tell you that she's very committed, dedicated to moving the malaria elimination agenda in South Africa and in the Southern African region. The third speaker that we would have on the panel today is Aaron Mabuza. Aaron Mabuza, as I said, he co-chairs the South African Malaria Elimination Committee with Professor Karen Barnes. He's very instrumental in way back in the years in malaria control, but more recently supporting malaria elimination efforts in South Africa. Aaron Mabuza has over 40 years experience in malaria. In fact, he was given the Lifetime Achievement Award for malaria in supporting South Africa in its malaria efforts by the Medical Research Council. He has also improved community protection against disease and recognized the need for and contributed to research into developing better methods for malaria parasite and mosquito vector control. He's currently supporting KwaZulu-Natal, Limpopo, and Mpumalanga. These are our 3 malaria endemic provinces by providing technical advice on malaria program management and key technical issues regarding malaria strategies and malaria implementation activities. So this is the lineup we have, very, very experienced panelists. And we will start firstly with Professor Barnes, then we will move to Dr. Jayashree Raman, and then we will end with Aaron Mabuza, and then we'll have an opportunity for you to take some questions and some an answering session. With those words, I hand over now to Professor Karen Barnes, and they will continue until the presentations are all over. Over to you, Professor Karen Barnes.
Thank you very much, Dr. Manasa, and thank you to the Honourable Minister and the Ambassador for keeping the malaria agenda high despite the COVID pandemic. It's absolutely essential that we keep fighting malaria together to make sure it is defeated. And we'd like to focus today on the role of community involvement. Next slide, please. So as the Minister has highlighted, one of the big advantages we have with malaria is that it can be prevented. It's not only treatable and curable, but it can be rapidly diagnosed. And as you will all know, with COVID, it's a frustration that there's always a delay between taking a sample and getting the result. With malaria, within 15 minutes, your nurse or doctor can know whether or not you need malaria treatment. And that combination of factors really makes it a feasible goal to eliminate malaria in South Africa. Next slide, please. We're focusing on community involvement because all of the great tools that we already have and the new tools that are becoming available depend entirely on achieving community buy-in. The ability to control mosquito vectors that infect people with malaria requires people to allow their households to be sprayed with insecticide, people to sleep under bed nets, or if you're a traveler, to use insect repellent and insect repelling devices. As the Minister highlighted, last slide please, as the Minister highlighted, we also need for people to seek treatment within 24 hours of symptoms that could be malaria so that they can be treated quickly and then cure rates are high. We want to prevent the disease from progressing to severe malaria when cure rates are not as high. Lastly, we want communities to assist us in allowing case investigators to do their job, to understand, is this case an imported case or a locally transmitted case? Are there preventable factors around a household that put someone at risk of malaria? The same would apply to your guest house or tourist destination. Next slide, please. So far, South Africa has made good progress towards zero malaria. Here you can see the total number of cases, which have decreased markedly since the year 2000. However, in 2017, we were reminded how fragile our efforts to control and eliminate malaria are, and we need to work out how to prevent the outbreak that we saw a few years ago. These are the total number of cases, but what gives us hope for elimination is that we know that over 95% of our cases in KwaZulu-Natal are imported, so only 5% are local. And in Mpumalanga, only 85% are imported, only 15% local. And so the numbers there are small enough to be able to do everything necessary to be able to eliminate malaria. Next slide, please. We're not just eliminating malaria for the health of our communities. We know from what the minister reminded us, this is also really important for tourism, but it's equally important to the households that suffer from malaria. As Dr. Manosa reminded us, 10% of South Africa lives in malaria endemic areas. Some of those households are incredibly poor. And we've done research by surveying thousands of households, and we have found in those areas more than 10% of the households in South Africa incur catastrophic costs if they have a malaria case within their household. In neighboring Mozambique, southern Mozambique, up to 1/3 of households can incur catastrophic costs. So this should encourage us to help communities to do whatever is needed to reduce their risk of getting malaria. Next slide, please. One of the challenges we face when we succeed in dramatically reducing the number of malaria cases is it's no longer at the front of people's minds, in the communities, among tourists, among healthcare workers. As a result, mosquito control measures can be compromised. People choose not to have their household sprayed. They can delay seeking treatment, which obviously needs to be done within 24 to 48 hours for malaria. And even if they do seek treatment, if healthcare workers aren't aware of testing for malaria, they might miss the case, delay the diagnosis until someone has severe malaria. So I greatly welcome this opportunity to encourage community engagement and awareness so these problems are overcome. Next slide, please. In summary, we need for our households to welcome the teams from the malaria program that come to do indoor residual spraying, even in the COVID pandemic. The program is doing everything possible to mitigate the risk of COVID, and we need for people to encourage indoor residual spraying. Next slide, please. As we've all said, we also need people to seek treatment early, within 24 hours of developing the typical and common flu-like symptoms that could also be COVID symptoms and could be some other diseases. You can get to a clinic within 24 hours. Within 15 minutes, we'll know whether it's malaria, and you can be effectively treated with a medicine which cures almost 100% of cases. If this doesn't happen quickly, we risk people progressing to severe malaria within a few days. Next slide, please. We have highlighted with Ambassador Kamwi the great importance of regional cooperation. We may call ourselves separate countries, but we are one very closely connected region. Here you see how porous our borders are, how easy it is to walk from one country to the next. In the top left, you see tracking of mobile phone connections and how intimately connected our countries within the E8 are. Often we have families living on both sides of borders that are placed there for not very logical reasons. So regional cooperation, the efforts of the E8, the efforts of SADC, under the great leadership of our minister, is absolutely pivotal to us achieving our goal. Next slide, please. So in conclusion, I believe we can defeat malaria if we work together. We know that malaria can be prevented, rapidly diagnosed and treated, and therefore it can be eliminated. But we saw and were reminded cruelly in 27 that progress towards elimination can be fragile. So we need to keep our control tight. Regional partnerships are valuable and community engagement is essential. Together, we know that zero malaria, zero local transmission cases is possible. And it starts with each of us, whether you're a minister of health, a healthcare worker, or one of the local communities affected by malaria. Thank you so much.
Next slide. So Jayashree, Dr. Raman, you can continue with your presentation. Thank you.
Thank you very much. And I echo the sentiments of Prof. Barnes completely, that it's really appreciated that we have a seminar today highlighting malaria in all the COVID consumed world. And my task today is just to highlight some research priorities that are essential that countries consider when trying to drive the elimination agenda. Next slide, please. So first, I just think it's really important for everyone to realize the difference between control and elimination, because it does have a very great bearing on what we need to do. So in control, the main aim is to reduce the burden of the disease by reducing malaria morbidity and mortality. And you really apply a area-wide, regional, universal approach to any intervention you apply. This all changes with elimination. It becomes very specific because what you're trying to do is stop local transmission in a very defined area, principally by tracking and treating every malaria case, whether they're symptomatic and asymptomatic, terms I'm sure you're very familiar with now following COVID-19. And the interventions then have to be very targeted, focused, and very tailored towards the area which you are trying to eliminate malaria. So this gives you a clear indication that you need very accurate current information to inform intervention targeting. Next slide, please. And so for research priorities, I've created 3 buckets that I think are essential. And the first one might seem most obvious, but it's obviously sometimes not very obviously known, is to know where the parasites and vectors are. Because as you move to elimination, they tend to become much smaller populations and more dispersed. So we need to know specifically if they're in the community, where in the community, and if it's moving between borders or moving between provinces, exactly where are they moving, so you can actually target your interventions. The next is also knowing where your vectors are. Are they in rivers away from the community, or are they in water streams or water puddles close to the community? And here the communities have a great role to play in trying to reduce areas where water can collect and reduce the areas that malaria mosquitoes can breed, and therefore also reduce the burden of malaria. Next slide. So once you know where your parasites and vectors are, the next thing is to know what your species are. And this has great impact on whether your intervention task is going to be. So knowing your species of parasite is going to influence your diagnostic tool. So for example, in South Africa, most of our infections are by falciparum malaria. So we have a rapid diagnostic test that detests primarily falciparum malaria. Whereas if you're in an area where you're going to have a number of other malaria species infecting, you're going to have to use another diagnostic tool. Also, what species is prevalent in the area is going to determine what treatment is available, because different parasites need different types of treatment. It's the same for the malaria vectors. Different types of vectors are going to be affected by different types of vector control. So for example, if you have the vectors that bite you indoors and stay indoors, indoor residual spraying is going to be very effective in killing them. Whereas if you have mosquitoes that are going to bite you indoors, but then fly outside to rest, indoor residual spraying is going to have reduced impact. So you're going to have to modify your interventions based on the malaria behavior. of the behavior of malaria mosquitoes, sorry. So you really have to know. So once you know where your malaria is, you've got to know what your species are. And lastly, the next slide, please, and probably most importantly, in my opinion, is actually knowing the interventions that you're going to use if the malaria parasites and vectors are going to be affected by it. And the most primary important thing to find out is whether they are susceptible to the insecticides and antimalarials. And South Africa is a prime example of where we had very good interventions that had very high coverage, but we didn't do this regular monitoring. And that resulted in the outbreak in the 2000s. That was primarily driven by the emergence of both parasites and mosquitoes that were resistant to the insecticides and antimalarials. So what we need to do, next slide, please, is ensure that we have regular monitoring of insecticide effectiveness against the mosquitoes and have plans in place to make sure that we can rapidly change if we detect insecticide resistance emerging in a population, so we don't get the 2000 epidemic outbreak. It's the same thing for the parasite. You have to constantly make sure that the parasite is sensitive to the drug. And because we've managed to reduce the case management in caseload in South Africa so significantly, what we have piloted in Nkomazi sub-district in Mpumalanga is trying to track down right down to the facility what parasites are circulating. So we've come up with quite a novel idea where we collect the used malaria rapid diagnostic tests, use them as a source of parasite DNA, and then do drug resistance marking. And then we're able to mark down right down to a facility level the type of parasites that are circulating, so we can identify problem areas and allow prompt containment activities to take place so we don't get an outbreak like 2000. Next slide, please. So all this research has been used in the SADC region, and I thought it was really important to show what research can do and how it can influence and rapidly accelerate towards elimination. So as Prof. Barnes mentioned, there was some research showing the rapid movement and great movement between people in the SADC region. So a question was asked, well, so does this mean that because parasites and mosquitoes don't respect borders, do these people carry the different parasites around the areas? And some neat work done along the border between Angola, Zambia, and Namibia showed that with great people movement comes great parasite movement as well, and showed that the parasites related in all these three countries were extremely related. So it then again highlighted the idea that if the SADC region wants to be malaria free, it cannot do it by country alone. It has to be a regional approach. Next slide, please. And that gave rise to many cross-border collaborations, all very, very efficiently monitored and supervised by the Elimination Aid, which has managed to ensure all countries have harmonized their malaria control intervention. So if one country is doing IRS on the border, they make sure the other country is doing it at the same time, which prevents mosquitoes moving away from any areas where they might be negatively impacted. But one of the most impactful interventions that the Elimination Aid has put in place has been malaria border posts between the frontline 4 countries and the second line countries. And what these border posts do is they test and treat anybody that is crossing the border with symptoms or without symptoms. And they will treat you with no cost to the person for malaria. Next slide, please. And since these border posts have been put in 2015 in these 8 countries, they've tested just under 2 million people and tested positive about 750,000 people that have been tested and treated for malaria on site. And this has resulted in a major reduction in malaria in these border areas, which has allowed the frontline 4 countries to get closer to elimination and also help the second line countries move closer from control towards maybe elimination. And this research and collaboration between the E8, my last slide, please, has highlighted the need that we all need to collaborate and work together in an interconnected area like the SADC region, because zero malaria starts with me. Thank you very much.
Thank you very much, Dr. Raman. We'll now have Mr. Mabuza. If you can just take us through your slides, please, sir.
Thank you. Dr. Manasa. Next slide. Now, I'm going to outline these topics: introduction, operationalization of malaria and elimination in the field, importance of indoor reservoir spraying, and importance of case investigation. Please. Yeah, before I wanted to say that without cooperation, we cannot, elimination strategy cannot happen in the field. So we need the cooperation with the community. We need malaria program team. We need cooperation with the Department of Health, with other departments as well, and our partners. Another slide. So in operationalization of malaria elimination in the field, this means elimination is not an easy task. It requires more resources, of which we need to conduct some situational analysis for identification of gaps before we can draft the implementation plan and cost it. Thereafter, we need to begin with consultation of the political figures, mostly at provincial, municipal, and community level, that we need to buy in them so that when we go to the community, we are known, they know what we're doing. And also we need a collaboration with the neighboring countries through cross-border initiative, e.g. Muswaso. We need to create capacity of our program staff at all levels, that they need to know that now we are no more doing control, we are doing elimination. So things need to change a little bit. And we need to train our primary health care workers, especially on the diagnosis and treatment of malaria, as well as notification. And that notification should be sent at the next level immediately for the program to carry some investigation. Next. Yeah, the importance of IRS. So IRS is the main method used in South Africa and one of the most effective and affordable. We have been using this, and that is why we're seeing the low transmission. IRS is targeting malaria parasite-carrying mosquito that enter our houses and feed on the occupants and transmit, feed on our occupants and rest in the house. Mosquito will be killed when resting on the spray surfaces. So they will pick up some lethal dose and die. And in that way, it cuts the transmission. IRS may therefore not be effective in the control of mosquitoes that bite and rest outdoor. Therefore, we are having the larval source management that we are implementing. And that larval source management is targeting the young mosquito, the baby mosquitoes that can, before they can grow to adult mosquitoes. Next slide. Indoor reservoir spraying is ideally used in areas where the following condition exists. The majority of vector population feed and rest inside the houses. That is why we call it indoor reservoir spraying, because we want to kill the mosquitoes inside that are resting inside. The vectors must be susceptible to insecticide in use. The night sleeping of people is predominantly indoors. So we cannot assist people that are sleeping outside because there is no way to spray Otherwise, we need to spray the space. Prevailing structures are suitable for spraying. So the structures that we are going to spray are suitable for spraying, because some of the structures are built with material that we cannot even spray. And even if you can spray, it cannot sustain the insecticide on the surfaces. Settlement further from health facilities. So we also consider to assist the people who are settled far away from health facilities. We think, and malaria is endemic in those areas. We always assist them with spraying. The importance of case investigation, it is the active search for malaria cases at community and at household level. So we are visiting those community to test people with fever, migrant, and travelers that recently travel, or people with history of traveling, and then we take some, we test them and treat them. Active case detection reduces malaria parasite load, and also also break transmission, because we test those people before they can even know that they are sick or get sick. There are two types of active case detection that we're using. The reactive case detection, this one is triggered by malaria notification from health facilities. So when we receive the notification, the program will visit the household of the patient and verify the traveling history so that they can be able to determine the source of infection, whether it's imported or local. And in those, when we visit those houses, we are doing a lot of things to check whether the structures were recently sprayed. We check the breeding sites and also do the spraying if the structures were not sprayed, and do the larviciding. And also monitor and also take some test the contacts and the neighbors. Proactive case detection, this one is about screening of for identification of symptomatic cases in the community at risk, and also the special migrant workers on the farms that we will just visit and do the interview of the people, Vusela, and those who are presenting fever, and then we test them and treat, and those who are visitors in the area, and then we also test for malaria. Thank you.
So thank you very much to all our panelists. You've heard from Professor Barnes looking at the key issues of policy and implementation, but also the message that she's given us regards community involvement. And if we improve and we reduce malaria, we eliminate malaria, then economic activity through tourism, but also personal income in houses, would be increased. Jayshree Raman, thank you for your presentation highlighting the research components, and Mr. Mabuza, the issue of scaling up indoor residual spraying and case finding. These are critical components for us to be able to get right so that we can move along to malaria elimination. We now turn our focus on the question and answer session. I see we have some hands up already, and we have also some questions and answers in the Q&A component of this webinar. But maybe I've seen someone by the name of Sibangani Dube, who's been having his hand up or her hand up for a while now. So over to you if you want to quickly ask us your questions. We can't hear you, Sibani. So maybe if you can also send your questions on the chat, that will also help. While we're waiting for the questions to come up on chat, we can ask Zakele Ngosi Sibaya, if you can give us your question, please. You need to unmute yourself. Okay, so okay.
I'm not sure if you can hear me now.
Yes, we can hear you. Go ahead.
Okay. No, my name is Zakele Sibia from eThekwini in Devon. So I wanted to bring up the point where one of the, I think the professor from University of Cape Town was talking about the delaying of seeking of treatment. So we are sitting with this same challenge here in Devon, where most of our imported cases that are coming from in our nearest countries, so they come and then later, then they will experience signs and symptoms. Then they will delay seeking of a treatment, of which I think for us we have a big challenge when it's coming to that, because most of our cases they present to our facility at a later stage.
Okay, thank you. We'll just quickly note those questions. Note that question down, Professor Barnes, and then we'll see if there's any other hands up or if there's any questions in the chat line. Just trying to find those questions. So there's a question here from Perfect Saniego. What are the effects of IRS on people? If the wall is sprayed and children lick the wall, what effects can happen, if any? So Mr. Mabuza, if you can take that question, and that will be good. So while other questions are coming up, Professor Barnes, if you want to quickly just take us through the response for the colleague from eThekwini. Go ahead, Professor Barnes.
Thank you, Dr. Monasan. Thank you, Zakeli. I think that's one of the key reasons why we are together today, is to work together with partners in the media to disseminate that really, really important message that COVID is not the only threat to our health, and that malaria signs and symptoms, whether you live in a malaria area or you visited it, that to seek treatment, and that it's easy to be tested, and it's a rapidly curable disease if we seek early. So I think we need to all work together to disseminate those messages. So thank you very much for highlighting that important question.
Thank you. Mr. Mabuza, if you can just take us through the issue of the indoor residual spraying on people. If the wall is sprayed and children lick the wall, what effects can happen, if any?
Yes, thank you for the question. When we are doing the spraying, first of all, we cannot just go and spray without educating the community. The community is educated, and we are also given instruction when we arrive and to conduct the spraying that children must be taken away, everybody must be vacating the house. And even the pets, cats and dogs should be out, not inside. And then we sprayed. After spraying, they must wait outside until the walls or surfaces are dry. So when they are dry, and then they will come and sweep. And then after that, it's not effective to the children or any occupant that may enter. So it's safe. So they must wait about an hour before they can use the structures.
Dr. Kamwi, thank you. Dr. Kamwi, I can see you want to say something. I know you're also a malariologist. Maybe if you want to add a few comments.
Thank you very much indeed. First, I think I must commend the brilliant presentations by the three presenters. And they all the emphasis in all was collaboration and collaboration. Yes, indeed, I cannot agree more with my brother, Mr. Mabuza. Many a time we do receive such complaints, our cats dying because of spraying, our chickens dying because of spraying. There is no truth in such allegations. Education is key to our communities. And yes, indeed, our spray men and women are always educated before the spraying cycle can start. Therefore, what my brother Mabuza stated, there's no truth than that. I had never experienced any such death or a related death resulting from a child, as a result of spraying, a child dying, chicken dying, whatever. Never in more than 30 years that I have been in malaria. So let's continue educating our communities. And our communities, once they are educated, they are simply empowered. We will see by the end of the tunnel, elimination will be realized. Thank you.
Thank you. We have a question here from Mbui Kalonyi. Is there a symptom unique to malaria? The ones mentioned here are similar to what we have heard about COVID-19 and even listeriosis. Flu can also lead to headaches, muscle pain. Isn't this why people go to hospital late? Professor Barnes, can you just take that one quickly for us, please?
Certainly. And Boy, you're quite right. It's a very clever parasite that's been around for a very long time. And I think one of its tricks is that there's nothing unique about it that will make people be able to tell clinically that this is malaria, it's not flu, it's not something else. And so that's why the messaging is particularly challenging, because of course people will hope flu gets better and they might wait a few days. So it's purely a communication solution that we have to offer. We don't have a unique symptom for you, but we do have the advantage of a rapid diagnosis once people present with any symptoms that could be malaria. And as we get closer and closer to elimination, of course, a lot of those tests will be negative, and we will then treat people for the other diseases it could be. But without getting to a health facility and getting that test done early, we haven't got a way to be able to treat people early, other than the interventions that Dr. Rahman was describing, where we have border posts where people, whether they're symptomatic or not, if you're crossing the border, we test and we can treat people without symptoms. And so that's all we have to offer. Thank you for that question.
Thank you. We have a question from Frank Kagoro. What are the efforts in place to support cross-border data sharing? And how is readiness of the SADC countries towards data sharing? I don't know if Dr. Rahman wants to quickly take this one, and maybe I can also supplement from my knowledge.
Sure. It is one of the biggest challenges, sharing data, but definitely the E8 has facilitated and started the process of sharing. It is not as robust as we'd like and as frequent, but it's definitely starting. And I think more countries are beginning to see the need and the value of sharing data to be able to react promptly to outbreaks. And I think the COVID-19 outbreak has definitely helped prove how important it is to have prompt data and access to data. So I think it's improving. It's not the best situation, but we are getting there. Thank you.
Thank you very much, Dr. Rahman. Maybe just to quickly supplement that from the knowledge I have, definitely the Elimination 8 has set up what they call a war room. So every week, program managers meet and epidemic preparedness and response offices to review the data, especially now during the transmission period. The cross-border initiatives, there's also data sharing occurring there on through the Mosaswa initiative and the E8 initiative. But obviously, as Jayshree has mentioned, there are challenges, but we try our best to see how we can improve this going forward. There's a question for Professor Barnes. What contributed to the increased malaria cases in 2017 in South Africa? Can we see a similar event in the future?
Thank you for that question. It's a difficult one to answer quickly because I think multiple factors were involved. The things that we investigated and were reassured about is that our drug treatment is still working and highly affected. So it's not the same problem that we faced in 2000, where we had both insecticide and drug resistance. The other thing that we think was really important was that people started to forget about malaria at all levels, at the community, at health facility level. And so we weren't on our guard. And then when things happen, like it gets warmer or it's more rainfall and there are more mosquitoes around, you can get a rapid spike developing like that. The last straw was that this was a challenge across the whole region. So then there started to be shortage of commodities. And so we were running low on tests, we were running low on drugs, even the manufacturers were running low across the region. And of course, that made the situation worse. And so it's really important that we now have the E8 and the war room that Dr. Manasa has spoken about, so that we are ready for any attempt of the malaria parasite and the vector mosquitoes to try and get on top of us again. Thank you.
Thank you very much. Minister Mkhize, there's a comment, but I would like you maybe to give a bit of a response on this from Samson Katikiti, and he's from the African Leaders Malaria Alliance, where he says that it's not a question, but a comment to congratulate all the speakers and also all the E8 countries for having been able to have their IRS commodities in time despite the COVID challenges. Countries, the Elimination Aid Secretariat and partners helped in tracking these commodities, so very good. The challenge we have is how we move swiftly to deploy these commodities in the shortest possible time before malaria cases pick up. So Minister, maybe the question for you as the new chairperson for the Elimination Aid Initiative is, how can we accelerate delivery on malaria in the region, keeping in mind malaria does not respect any borders and it does not even respect bureaucracy. Minister, any comments from you in this regard? Thank you.
Thank you very much for the comment. I think that the real issue of the E8 as a focus program is to be able to allow quick interaction of the people who are involved in the program, so that whenever there are obstacles, they could be easily resolved. Let me give you an example. When we're dealing with the COVID-19 situation, you could get a call about a problem that's happening in a border between South Africa and Zimbabwe, something that would have gone through a lot of bureaucracy before it reached the top leadership. And it can be resolved on the spot. And you found people who were stuck in the border between Mozambique and South Africa, and the issues had to do with the application of the rules, the delay in the logistics, the closure of the borders. And all of these issues could actually be resolved fairly quickly because there was an understanding we're dealing with an emergency. So there was a kind of rapid response line. Now, E8 the elimination program will help us to keep this team of leadership to be able to pick up areas where there are quick interventions that are needed. The need for malaria-related commodities to move swiftly to reach the areas of deployment is something that needs to be worked on, so that no one can sit and say we haven't started spraying because our trucks are stuck on the other side of the border, and that the customs are saying that the papers needed to be signed in triplicate, and therefore we can't move on. So you need some way of being able to pick that up and say, well, the timelines we have is by this date, these commodities must have reached this point, and therefore do everything to eliminate the blockages in between. I think that issue is going to be very important. And I think the point that's been raised around community awareness, the biggest point, I think where Professor Barnes raised this, I can't be sure whether probably it was Dr. Rahman who raised the question of having to actually align I think all of the panelists raised it, was the question of aligning the treatment, the testing of individuals with immediate treatment. It has to be linked to the knowledge of the community, so that people must know they need to cooperate, they need to make themselves available, and therefore they need to be treated. If somebody was skipped and was not there, must be tested and be treated quickly. So the question of investing in the knowledge of the community becomes very, very important, because to be honest, like we have learned on COVID, it is the community that must fight malaria, and then we as the technical experts will then give them support, give them the treatment, give them all the tools, but they, with their knowledge, they must know that they are the ones who must lead the fight. So I think that it's an important issue of aligning the question of removing the blockages, investing in the communities, and of course, excuse me, and of course partnering with the media, because a very strong message will be easier understood if it came from radios and TVs about why people need to do this and why it is important that they must all be treated and so on, and send the correct information. Sometimes we've got this problem of fake news. The only way you deal with that is that we all partner and send the right information, be available to share the information at the right time. Thank you very much.
Thank you very much, Mr. Minister Mkhize. We have time for one last question, and we're going to take it from Tanya Patterson. She says that in healthcare, according to Integrated Management of Childhood Illnesses, IMCI, when screening children who present with a fever, we are required to assess malaria risk, i.e., whether the child lived or visited a malaria zone during the past 4 weeks. How often is the list of malaria endemic countries updated, and how is this made available to healthcare workers? I'm going to ask Dr. Rahman if you want to quickly comment on this.
Sure. Thanks for that question. It's a very important question. So the risk maps are regularly updated, and we try to get that information out as often as possible. And we definitely try to distribute it to all the healthcare networks possible. There's something else I just want to raise here, because I think this is a really important point. I know you say you need to screen if they've traveled to a malaria area, but we do have this instance of Odesian malarias where somebody hasn't traveled, but a mosquito has hitchhiked a ride into an area where and bitten the person. So even if the child hasn't traveled to a malarious area, there might be a possibility of having malaria. So, you know, a malaria test, an RDT, is a quick result, and I think it's worthwhile doing the test rather than not doing the test at all and waiting until later. Thank you.
So thank you very much for that, Jayshree. We have a few minutes left, so what we will do now is very quickly, Ambassador Kamwi and Minister Mkhize, if you have any quick comments in terms of concluding remarks, and maybe we'll ask the panelists as well, short and sharp, because of our time restrictions. Minister Kamwi, is there any concluding remarks from the Elimination 8?
Thank you very much indeed, Patrick, Honorable Minister and members of the panel. One, there was that question on the epidemic, 2017. E8 and WHO investigated the cause. What prompted that epidemic? I cannot agree more with Prof. Karen Barnes. It is related to the presentation by Prof. Karen and Minister Mabuza. The member states, all 8, only one survived it, and that is Eswatini. The reason behind that, member states did not meet with the WHO requirements in terms of IRS, indoor residual spray. They were all below 80%. Some of them even around 40% in all the malaria areas. Yes, indeed, finally, there is need for member states to collaborate. We are faced with one common enemy, and this common enemy does not carry passports whenever we move. Data sharing is important. As Ubuntu, you can only support your neighbor when the fire is on. Thank you very much indeed. Over to you.
Thank you very much, Ambassador Kamwi. Minister Mkhize, any concluding remarks from you, sir?
Thank you very much. Thanks for hosting this seminar, and thanks to all the panelists for the very detailed knowledge that they have shared. I think our focus has to be, we shouldn't miss the 2023 deadline. We should take it as a campaign of all South Africans and our neighbors working together. It is important for us to know that government has to be in the forefront, communities have to be in the forefront, business has to be part of the partnership. So working together with civil society, we should be able to mount a very strong campaign to eliminate malaria. And we must know that when we do so, we're investing in a healthier population, we're investing in a stronger and vibrant community, particularly the tourism, the transport, the logistics sector, of course, as well as healthier communities who are able to visit each other without a fear of being afflicted by malaria. Thank you.
Thank you very much, Minister. I think that all that's left for me to say is a few points. That the regional collaboration, Elimination 8, is an important initiative together with other cross-border initiatives, because malaria will not be eliminated in a country alone. It must be eliminated through a regional collaboration. South Africa's leadership will be required to supporting elimination in the region. And Minister, with your leadership, with the Ministers' Council, I think we'll be able to move this elimination agenda with the speed that it deserves. Malaria is a preventable, a treatable, and a curable disease. No one needs to die from this disease. Research is very important to informing malaria policies towards elimination. And as you heard from Aaron Mabusa, that making sure we have effective, high coverage, universal coverage of indoor residual spraying for vector control, and ensuring that we have case finding and treatment through active case detection is absolutely critical. The other point I wanted to make is to say a big thank you to Ambassador Mkhize, to say a big thank you to Minister for taking time out of your busy schedule for supporting this very, very important SADC Malaria Day event. And to all the panelists, you've heard from the best that we have in South Africa. Professor Barnes, thank you very much. Thank you very much, Dr. Raman, and thank you very much, Mr. Mabusa. But I want to end by reminding us of the slogan and the theme for today, and we should carry it through for the rest of the year as well. Community involvement is key to achieving zero malaria. Together, we will defeat malaria. Thank you very much. And with those words, we end this webinar for today. Thank you and bye-bye. Can I leave?